Good morning. I'm Sir Franz, and our focus is congestive heart failure. Today, we are going to define congestive heart failure, describe its etiology, pathophysiology, and how we treat it. Our main reference for this lecture is Goodman and Gilman's chapter on the therapy of heart failure. Congestive heart failure is the pathophysiologic state in which the heart is unable to pump blood at a rate commensurate with the requirements of metabolizing tissues, or can do only from an elevated filling pressure. The main causes of heart failure are the most common coronary artery disease, which is related to myocardial ischemia, hypertensive cardiomyopathy, which is the compensation of the left ventricle during hypertension that is primarily related to an increase in tissue, uh, an increase in total peripheral resistance, valvular heart disease, familial cardiomyopathy, which is genetically inherited or associated, other etiologies such as diabetes, alcohol, and cocaine. As you will notice, there are different pathophysiologic mechanisms in these five groups of disorders, but all of them converge into the common phenotype of heart failure. And this means that heart failure is um, a common um, pathway in heart disease. So heart failure can be easily grouped into heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. And here our goal is to understand that ejection fraction is a function of effective systole. In heart failure with reduced ejection fraction, the ejection fraction is usually less than 40 to 50%. So to quantify this, imagine that the left ventricle is filled with 100 ml of blood. An ejection fraction of less than 40 means that when the left ventricle contracts, less than 40 ml is ejected into the aorta. Heart failure with reduced ejection fraction is due to systolic dysfunction. And again, this is the inability of the left ventricle to pump blood into the aorta. It is a pump failure in itself. So, now direct your attention into these images. Here is the normal heart, and please notice the diameters of the left ventricular lumen. The insult that usually leads to heart failure with reduced ejection fraction is volume overload. There is too much blood. And this excess blood applies stress into the walls of the heart. The compensation of the heart against this stress is hypertrophy. But in this case, the hypertrophy occurs uniquely because the hypertrophy is directed outwardly. The heart enlarges to increase its diameter, the luminal diameter. And this type of hypertrophy is what we call eccentric hypertrophy. The end product of eccentric hypertrophy is a dilated heart. This is dilational cardiomyopathy that is due to volume overload. Because this ventricle is extremely dilated, whenever this contracts, the mechanics of the left ventricle is poor. And so systolic dysfunction occurs. In heart failure with preserved ejection fraction, the ejection fraction is maintained at greater than or equal to 50%. And again, quantifying that, if 100 ml of blood fills the left ventricle, an ejection fraction of greater than or equal to 50 means that 50 or more ml of blood is pumped out of the left ventricle during each contraction. However, the problem with heart failure with preserved ejection fraction is diastolic dysfunction. During diastole, in which the left ventricle relaxes and is filled with blood, because of the hypertrophy, there is luminal narrowing of the left ventricle. And so, the left ventricle will be able to accommodate less blood than usual. So, you will see here in this photo that there is a hypertrophic ventricular wall. And the main issue with heart failure with preserved ejection fraction is pressure overload. So that is the stimulus, and the response of the heart would be hypertrophy. But this time, the hypertrophy occurs so that it goes towards the center, and that constricts the lumen of the left ventricle. That type of hypertrophy is concentric hypertrophy. Okay. These two processes, eccentric, which leads to dilation of the heart, and concentric hypertrophy, which leads to a decrease in the luminal diameter of the left ventricle, are not exclusive. In patients, we see that these two combine. And so, in patients with heart failure, there is a combination of both systolic and diastolic dysfunction. Patients with heart failure with reduced ejection fraction are usually very symptomatic. And patients that we see with decompensation, acute decompensated heart failure, usually have heart failure with reduced ejection fraction. In heart failure pathophysiology, the cornerstone to understanding this concept is that the heart has reduced cardiac output. And so, the peripheral tissues do not receive blood. This will activate neurohumoral mechanisms, which means that these mechanisms involve the nervous system and hormone systems. Okay? So, the usual trend in heart failure pathophysiology is a vicious cycle. The reduced cardiac output will stimulate these neurohumoral mechanisms, and these neurohumoral mechanisms will then be able to increase cardiac output, but at the same time lead to structural and physiological changes in the heart, which will then aggravate the systolic and diastolic dysfunction that originally leads to heart failure. So again, that is reduced cardiac output, activation of the compensatory mechanisms, then worsening of the function of the heart. And so that loops upon itself, creating a vicious cycle. And this vicious cycle will continuously decrease the ability of the heart to pump blood. Okay, so the neurohumoral mechanisms that are involved are particularly those involved with volume and the sympathetic nervous system. So our initial insult due to heart failure is the initial pathophysiologic event is a decrease in cardiac output. With a decrease in cardiac output, the kidneys become less perfused. When the kidneys are perfused poorly, it secretes renin, thinking that it has to increase the fluids of the body so that blood flow to it is restored. So renin is released, and this is RAAS. Angiotensinogen secreted by the liver is converted by renin into angiotensin 1. Angiotensin 1 then flows into the pulmonary vasculature, where in the endothelium it encounters angiotensin converting enzyme, which converts angiotensin 1 to the potent angiotensin 2, which is a vasoconstrictor, and at the same time induces thirst mechanisms in the brain. When thirst is activated, the organism or the human increases water intake, and this again leads to an increase in blood volume. Angiotensin 2 also stimulates the adrenal glands to secrete aldosterone, which again acts on the kidney to increase sodium chloride absorption and together with it water absorption. So this leads to a decrease of sodium chloride excretion, and this leads to an increase in blood volume and pressure. So this increase in blood volume and pressure will then act again on the heart. Remember the insults in heart failure with preserved and reduced ejection fraction. Those are pressure and volume overload. Okay, another mechanism of decrease in cardiac output involves the brain. And once the brain senses that the cardiac output is decreased, it will stimulate sympathetic nerve activity. So this sympathetic nerve activity will feed into the heart, causing the heart to increase its stroke volume and heart rate, and therefore cardiac output. But at the same time, this causes the heart to remodel because there is an increase in demand. Therefore, the heart must be able to hypertrophy to meet that demand for cardiac output. Aside from that, the sympathetic nervous system also integrates with RAAS as it stimulates secretion of renin and decreases sodium chloride excretion. Aside from that, the brain will also secrete antidiuretic hormone or vasopressin, which will act on the collecting tubules of the kidney to cause free water reabsorption. This free water reabsorption will then expand plasma volume and lead to an increase in blood volume and pressure, which again will lead to remodeling of the heart. So, to summarize the compensatory mechanisms in heart failure and the pathophysiology, it is a vicious cycle of low cardiac output, activation of neurohumoral mechanisms, and then worsening of the structural and functional activity of the heart, leading to a decrease again of cardiac output. Let's now go into the treatment of heart failure. As a review of the pathophysiologic mechanisms of heart failure, this slide summarizes the major events and the sites of drug action. Cardiac remodeling, leading to eccentric and concentric hypertrophy, leads to heart failure, which is pump failure. That pump failure leads to reduced cardiac output. And so, especially in decompensation, we can give drugs such as inotropic drugs, which strengthen myocardial contractility to solve reduced cardiac output. Reduced cardiac output will then activate RAS as low blood flow is encountered by the kidneys. The kidneys will secrete renin, which will act on angiotensinogen released by the liver to convert it into angiotensin 1. And at this point, this can be inhibited by renin inhibitors. Angiotensin 1 is converted to angiotensin 2 via angiotensin converting enzyme, and this can be inhibited by ACE inhibitors. Angiotensin 2 will stimulate the zona glomerulosa of the adrenal glands to secrete aldosterone, and this can be inhibited by angiotensin 1 receptor antagonists. Angiotensin 2 will also be able to act directly on the heart to produce cardiac remodeling or hypertrophy. Aside from causing volume and pressure overload, angiotensin 2 directly affects the heart. And this can be inhibited or slowed down by angiotensin 1 receptor antagonists. Angiotensin 1 receptor antagonists will also be able to inhibit vasoconstriction, which leads to an increase in cardiac filling pressure. And that cardiac filling pressure causes the heart to remodel. So by inhibiting vasoconstriction, you are also indirectly inhibiting cardiac remodeling. Reduced cardiac output also activates the sympathetic nervous system. And so, by activating positive inotropy, increasing the contractility of the heart, you decrease the need for sympathetic nervous system activation. The activity of the sympathetic nervous system can be inhibited by beta blockers, and this directly inhibits or slows down cardiac remodeling. Aldosterone leads to sodium and water retention. And so, at this point, sodium and water retention can be inhibited by diuretics. By using diuretics, we decrease cardiac filling pressure and we decrease cardiac remodeling. Aldosterone, like angiotensin 2, will also be able to directly affect the heart through cardiac remodeling. And so we can block the effects of aldosterone by blocking its receptor, thereby stopping cardiac remodeling and also stopping sodium and water retention. Diuretics reduce extracellular fluid volume and ventricular filling pressure. However, excessive diuresis is counterproductive, secondary to reciprocal neurohumoral overactivation from volume depletion. This means that whenever a patient with heart failure presents with fluid overload, it is but logical for us to help the patient lose that excessive fluid via diuresis or help that patient urinate. However, if we do so, if the diuresis is provided acutely, the patient will lose that fluid very rapidly. That rapid loss of tissue fluid causes the intravascular fluid to calibrate. So overall, there will also be a decrease in intravascular fluid. And that decrease in intravascular fluid will inadvertently stimulate RAAS and the nervous system to increase water reabsorption. And so, um, by doing diuresis acutely, you worsen the pathophysiology of heart failure and its compensation. Diuretics are effective in controlling congestive symptoms, such as those of difficulty of breathing and improving exercise capacity, but it is not associated with a reduction in mortality. So in patients with heart failure, by giving diuretics, you improve how they feel, but you do not decrease their risk of death. All patients with left ventricular dysfunction should limit dietary sodium intake to only up to 3 grams per day. So let's just take a quick review of the different agents. Loop diuretics inhibits the sodium potassium dichloride symporter on the apical membrane of renal epithelial cells in the ascending limb of the loop of Henle. It increases sodium and fluid delivery to the distal nephron. So what does this mean? By inhibiting the reabsorption of sodium, potassium, and chloride in the loop of Henle, these ions are delivered in greater quantities to the distal or lateral portions of the nephron. This means the distal convoluted tubule and the collecting duct. It enhances potassium secretion, especially in the presence of elevated aldosterone. Remember that the action of aldosterone is to secrete potassium so that sodium is reabsorbed in the collecting ducts. Again, aldosterone reabsorbs sodium, but at the same time to do that, it secretes potassium into the urine. If you add a loop diuretic, this enhances potassium elimination. Thiazide diuretics are usually combined with loop diuretics in congestive heart failure. It acts on the sodium chloride co-transporter in the distal convoluted tubule. And by blocking this co-transporter, sodium and chloride are not reabsorbed. It is associated with a greater degree of potassium wasting per fluid volume reduction. Again, here is highlighted the effect of aldosterone. Because the distal convoluted tubule is not reabsorbing sodium, and sodium concentration in the collecting duct increases, The compensation of the nephron would be to increase its sodium reabsorption in the collecting duct via the action of aldosterone. But to do that, it has to secrete or excrete potassium. And so thiazide diuretics are associated with potassium wasting. On the other hand, potassium-sparing diuretics, which will conserve the levels of potassium in the blood, inhibit apical membrane sodium conductance in the renal epithelial cells. These agents that directly act on the sodium channels are amiloride and triamterene, or potassium-sparing diuretics can also be mineralocorticoid receptor antagonists, which inhibit the action of aldosterone on its receptor. And examples of these drugs are eplerenone and spironolactone. Potassium-sparing diuretics in general are weak diuretics, but they are used to achieve volume reduction with limited potassium and magnesium wasting. They provide less fluid reduction, but they help with conserving safe levels of potassium and magnesium in the blood, which are important ions for rhythm of the heart. Oftentimes, patients with heart failure who are given diuretics on a chronic basis experience a decrease in the effects of these diuretics, and this is termed diuretic resistance. What are the causes of diuretic resistance in heart failure? Number one is non-compliance with medical regimen or excess dietary sodium. Understand that the effects of diuretics are centered on the elimination of sodium and water. And so if a patient who is on diuretics takes in a lot of dietary sodium, then the effects of diuretics are countered. Second, there is decreased renal perfusion and glomerular filtration rate. Remember that diuretics act on the kidney. In the kidney and in the nephron in particular, there are three steps: glomerular filtration, active tubular secretion, and passive tubular reabsorption. Whenever there is the use of diuretics, there is the risk of decreasing intravascular blood volume. When there is decreased blood volume, there ensues decreased renal perfusion. And when blood flow to the kidneys is low, the filtration of that blood and the production of urine also decreases. And so, with decreased glomerular filtration rate, the effect of these diuretics are limited. Another cause is NSAID use, which will cause vasoconstriction of the afferent arteriole, and so that will also decrease glomerular filtration. Primary renal disease, and the last cause is impaired diuretic absorption due to gut wall edema or splanchnic ischemia. So, patients with heart failure will have fluid overload. And where does that fluid accumulate? In the potential spaces, such as in the lungs, in the abdomen, and in the pericardium. No? So, whenever there is excessive fluid accumulation, this fluid may also dam up in the intestines. So when this happens, the intestines are edematous and they swell. When they swell and are edematous, their function of absorption decreases. So patients with heart failure with gut wall edema will not be able to absorb the diuretics that are given orally. And so that is also a cause of diuretic resistance. Remember that in heart failure, forward flow of blood from the heart decreases. And so, blood flow into the intestines also decrease. And that is called splanchnic ischemia. So when that happens, the function of the intestines also decrease. And one of that function is absorption. This will lead to decreased diuretic absorption and thus diuretic resistance. As a review, here is a nephron with the afferent arteriole and the efferent arteriole. So, NSAIDs will block this portion of the glomerulus. Okay, so NSAIDs will decrease the levels of prostaglandin, and when the levels of prostaglandin decrease, there will be less vasodilatory effect in the afferent arteriole. And so, this afferent arteriole constricts when you take NSAIDs, and so glomerular filtration rate decreases. Okay, so thiazide diuretics act on the sodium chloride symporter and therefore prevent the reabsorption of sodium and chloride in the filtrate. And thiazide diuretics act on the distal convoluted tubule, which is at this point of the nephron. So this is the glomerulus, the Bowman's capsule, the proximal convoluted tubule, the loop of Henle, the thick ascending limb, and the distal convoluted tubule. Here in the DCT is where thiazide diuretics act. Loop diuretics will act on the thick ascending limb. So this is the descending limb, the thin descending limb, and the thick ascending limb of the loop of Henle. So this is where diuretics act. Loop diuretics will prevent the reabsorption of sodium, potassium, and 2 ions of chloride. And so, by doing so, loop diuretics will increase the levels of these ions in the distal convoluted tubule. Okay. And lastly, our potassium-sparing diuretics act on the collecting duct, where the action of aldosterone causes sodium reabsorption at the expense of potassium excretion. So potassium-sparing diuretics can directly block this channel, and the type of potassium-sparing diuretic here would be ENaC, epithelial sodium channel inhibitors. Examples are amiloride and triamterene. Potassium-sparing diuretics can also be in the form of mineralocorticoid receptor antagonists such as spironolactone and eplerenone, which block the activity of aldosterone on its receptor. So with decreased aldosterone activity, the products of aldosterone, such as sodium-potassium ATPase, decreases. So when this enzyme decreases, there won't be gradient of sodium. Remember that the sodium-potassium ATPase causes the efflux of sodium so that sodium levels intracellularly decreases. This low level of sodium is what is needed for sodium reabsorption from high sodium concentration to low sodium concentration. So this low sodium concentration is because of this enzyme, sodium-potassium ATPase. And this enzyme is a product of transcription by the aldosterone mineralocorticoid receptor complex. So low levels of this, there won't be low sodium inside the cell, no sodium reabsorption. As you will remember our lecture in hypertension, there are a lot of drugs that act on blood vessels to cause dilation. But only these three types of vasodilators are shown to improve survival in congestive heart failure, which means that when we give these three vasodilators, patients do not die as often as they would when they have congestive heart failure. Their survival increases and their mortality decreases. And therefore, these three drugs have mortality benefit. These are the combination of hydralazine and isosorbide dinitrate. Next, ACE inhibitors and angiotensin 1 receptor antagonists, or ARBs. Nitrovasodilators are nitric oxide donors that activate soluble guanylate cyclase in vascular smooth muscle, which leads to vasodilation. Again, nitric oxide will activate guanylate cyclase, an enzyme that converts guanosine triphosphate into cyclic guanosine monophosphate. An increase in cyclic guanosine monophosphate will lead to dephosphorylation or removal of the phosphate of myosin light chain kinase, which will lead to vascular smooth muscle relaxation and then vasodilation. Through the action of nitrovasodilators, there will be venodilation, which means that the veins will vasodilate and therefore their space for holding blood will increase, and therefore there will be a decrease in venous return and a decrease in preload. It augments peripheral venous capacitance, how much blood is stored in the veins. And this results in preload reduction and a decreased left ventricular filling pressure. However, what we see in nitrovasodilators is nitrate tolerance. So, nitrate tolerance means with chronic use of nitrates, their effect continually decreases. This limits long-term effectiveness, and this is managed by permitting levels of the nitrovasodilators to fall for at least 6 hours each day, which means that a patient will have to stop taking nitrovasodilators for 6 hours each day. So the levels of nitrovasodilators would have to decrease in blood for 6 hours so that their effect is continuously produced. Okay? Remember that these that drugs, if they are continuously in high concentrations, the natural effect would be to decrease their receptor sensitivities. So high drug levels for a chronic period leads to decreased receptor sensitivity. And so by allowing 6 hours each day with low nitrate levels, there will be an increase in that 6 hours after, there will be an increase in receptor sensitivity. So allow the patient to not take nitrates for 6 hours. Hydralazine is a direct vasodilator with poorly understood mechanisms. We don't know yet how it works. However, by causing arteriolar dilation, It reduces right and left ventricular afterload by reducing systemic for the left ventricle and pulmonary vascular resistance for the right ventricle. This leads to augmentation of forward stroke volume and reduced ventricular wall stress. If the left ventricle won't have any friction or resistance, blood flow out of the left ventricle will be easier. And because of that, there will be reduced ventricular wall stress. With decreased wall stress, you are helping prevent pressure overload and therefore compensation, which is the concentric compensation, concentric hypertrophy. The last type would be angiotensin inhibition. So this is important to remember that angiotensin 2 has these effects in the cardiovascular system. Number one, it is a potent arterial vasoconstrictor. It is an important mediator of sodium and water retention. It modulates or strengthens neural and adrenal epinephrine release. It is arrhythmogenic. It promotes vascular hyperplasia, and it causes myocardial hypertrophy. And lastly, which is dire, it induces myocyte death. So this is the renin and angiotensin system, but here in this image, you will see an extensive fate of angiotensinogen. What we learn repeatedly is this straight pathway. But you will notice in this image that angiotensinogen can be acted upon by different enzymes, not just angiotensin converting enzyme and renin. Okay, and so angiotensinogen originally, as we know, is acted upon by renin to produce angiotensin 1. And angiotensin 1 is acted upon by angiotensin converting enzyme to produce angiotensin 2. And angiotensin 2, to produce the effects we have discussed a while ago, will have to act on its receptor, the angiotensin 1 receptor. However, angiotensin 1, if we block angiotensin converting enzyme using ACE inhibitors, can still be converted into angiotensin 2 via the action of kinase. And this pathway right here represents an escape mechanism by which angiotensin 2 levels can still rise. Okay. What's also important is that angiotensinogen, instead of being acted by renin, can be acted upon by kallikrein. Kallikrein is an enzyme that is activated by bradykinin. And bradykinin, when it activates kallikrein, converts angiotensinogen into angiotensin 1 to 12. This form of angiotensin is vasodilatory. So, I have already emphasized two things. That number one, there are alternative pathways, and number two, not all of the effects of angiotensin is vasoconstrictive. Some of them will have vasodilatory effects. Okay, one of that is when angiotensinogen is acted upon by kallikrein. This form of angiotensin is vasodilatory. What happens when we block angiotensin 2 activity on its receptor by providing ARBs, angiotensin receptor blockers? So this pathway right here will be blocked when we provide ARBs. And so angiotensin 2 will accumulate. Once angiotensin 2 accumulates and cannot act on the AT1 receptor, it will be acted upon by another enzyme, AP, which converts angiotensin 2 to angiotensin 3. And this side right here, this one, angiotensin 3, these forms of angiotensin are vasodilatory. And so, by blocking the effect of angiotensin 2 on its receptor, we not only prevent vasoconstriction, but we promote vasodilation. Okay? Here, introduced is the enzyme neprilysin. Neprilysin is an enzyme that degrades natriuretic peptides. So, natriuretic peptides, as the name implies, are hormones that cause the elimination of salt and water via the urine. They are natriuretic. And so, in heart failure, there is observed a decrease in the ability of the heart to produce these natriuretic peptides. So these levels are low in patients with heart failure, or their effects are low. Okay, so one form of therapy that is quite recent is to provide angiotensin receptor blockers with neprilysin inhibitors. And by inhibiting neprilysin, we are increasing the levels of brain-derived natriuretic peptide and atrial natriuretic peptide. And so BNP and ANP will be able to promote natriuresis and diuresis, therefore help in the pathophysiology of heart failure. So the third class of vasodilators will be angiotensin inhibitors. The first one, angiotensin converting enzyme inhibitors. ACE inhibitors are preferential arterial vasodilators. In the many forms of vasodilators, ACE inhibitors are preferred in heart failure. If we can give this to patients, that would be better. Angiotensin converting enzyme inhibitors suppress angiotensin 2 production. It decreases sympathetic nervous system activity, and it potentiates the effects of diuretics in congestive heart failure. So, remember that when diuretics are given, blood volume is reduced, or the tissue fluids are reduced by diuresis, elimination of salt and water. And so when a patient is given diuretics, that same patient will increase compensatory mechanisms to prevent water and sodium excretion. And one compensatory mechanism is by hyperactivation of RAS. And so when diuretics are given and angiotensin converting enzyme inhibitors are also given, this escape mechanism or compensatory mechanism of the body in response to diuretic use is also inhibited. And so it potentiates the effects of diuretics. Bradykinin production stimulates the synthesis of nitric oxide, cyclic guanosine monophosphate, and vasoactive eicosanoids. Remember that bradykinins are natural vasodilatory substances produced by the tissues of the body, particularly blood vessels. Bradykinin is degraded into inactive forms by angiotensin converting enzyme. And so, by inhibiting ACE, we naturally increase the levels of bradykinin. So, by increasing the levels of bradykinin, we also increase the levels of nitric oxide, cGMP, and therefore vasodilation, and vasoactive eicosanoids such as prostaglandin. So, the effects of angiotensin-converting enzyme inhibitors in the elevation of bradykinin represents a second mechanism of action. The first is the decrease in angiotensin 2, and the second is an increase in bradykinin. Remember that angiotensin 1 can still be converted into angiotensin 2 via the action of kinase. And so, that is the escape in giving angiotensin converting enzyme inhibitors. However, even with that escape mechanism, there is still seen in patients with heart failure a decrease in their mortality if they're still given with ACE inhibitors. And that um, decrease is purported to be due to the effects of bradykinin. Okay, so this second mechanism takes over whenever the escape is activated. So bradykinin, however, is associated with angioedema, which is a fatal adverse effect of ACE inhibitor use. Angioedema means widespread edema or fluid accumulation. Remember that angiotensin converting enzyme inhibitors promote vasodilation. And with vasodilation, net filtration pressure increases, and that leads to edema. Okay, so angioedema is fatal, and once we see this in patients, that means that patient should stop taking in ACE inhibitors and should never be given ACE inhibitors again. Bradykinin, if elevated, will also cause coughing, and the coughing is due to swelling of tissues in the lungs, which will lead to stimulation of lung receptors or lung nerve endings for coughing. So the prior two are solved by substitution with angiotensin 1 antagonists, angiotensin 1 receptor antagonists, or ARBs. Switch the patient into an ARB. ACE inhibitors are associated with mild elevation in serum potassium. How does this happen? So, by decreasing the levels of angiotensin 2, there won't be stimulation of the release of aldosterone. With low levels of aldosterone, there won't be any sodium reabsorption in the expense of potassium excretion. And so, the levels of potassium in the blood will continuously increase. There is superior vasodilatory effect of angiotensin converting enzyme inhibitors, and this translates to a reduction in congestive heart failure mortality. Angiotensin 1 receptor antagonists obviates or solves the angiotensin 2 escape mechanism that is associated with ACE inhibitor use. Again, this escape mechanism is the conversion of angiotensin 1 into angiotensin 2 that is not angiotensin converting enzyme dependent. Angiotensin 1 receptor antagonists decrease the probability of developing bradykinin-mediated side effects. Next, let's now focus our attention into antagonists of aldosterone. Left ventricular systolic dysfunction, or the inability of the left ventricle to pump blood, decreases renal blood flow and results in overactivation of the RAAS and may increase the circulating levels of plasma aldosterone up to 20 times. Here is an important summary of the roles of aldosterone in heart failure and its mechanisms. First, aldosterone leads to edema and elevated cardiac filling pressure. It is arrhythmogenic, or it induces abnormal heart rhythms and thus increases the risk of sudden cardiac death. It potentiates the effects of norepinephrine. It reduces parasympathetic activity. It leads to remodeling and ventricular dysfunction, and increases the excitability and contractility of cardiac myocytes, which will lead to pathologic remodeling, but at the same time is compensatory um, to increase cardiac output. So that is a two-edged sword. The mechanisms of aldosterone activity include increased sodium and water retention, potassium and magnesium loss, reduced norepinephrine uptake by the heart, reduced baroreceptor sensitivity, and so with decreased baroreceptor sensitivity, even if there is a commensurate compensation of an increase in cardiac output, the baroreceptors of the carotid and the arch of the aorta will not be able to detect this increase in blood volume, therefore continuously activate sympathetic nervous system activity. Aldosterone leads to myocardial fibrosis and alterations in sodium channel expression. Vasopressin receptor antagonists. So these are the factors that stimulate vasopressin secretion. Vasopressin is also known as antidiuretic hormone. So what factors lead to the secretion of vasopressin or ADH, antidiuretic hormone, from the posterior pituitary gland? Number one is serum hypertonicity sensed by pituitary osmoreceptors. So, whenever blood volume is depleted and the fluid in the blood is lost, then the concentration of solutes in the blood increases. So, the blood becomes hypertonic. When this hypertonic blood comes in contact with the pituitary gland in the base of the brain, the pituitary gland cells shrink because this hypertonic solution takes out the water from these pituitary cells. So when these cells shrink, they secrete vasopressin. Okay? The next factor is a perceived drop in blood pressure detected by baroreceptors. And these factors and mechanisms are dysregulated in congestive heart failure. Remember that in congestive heart failure, there is excessive tissue fluid, but at the same time, decreased intravascular volume. So what does that mean? The blood inside the blood vessels the volume of that blood is low, but outside those blood vessels, there is excess fluid. Okay, so these two um, physiologic mechanisms are abnormal in CHF, and therefore in congestive heart failure, there is an excess secretion of vasopressin. So here is the mechanism of anti-aquaioresis of vasopressin. Here is the basolateral membrane of the collecting duct. Here is the um, portion of the cell that comes in contact with the capillaries, to which inside those capillaries, the blood contains AVP. Okay, so AVP binds to the V2 receptor. Similarly, this is a G protein coupled receptor that activates adenylyl cyclase, increasing CAMP. Okay, so CAMP, cyclic adenosine monophosphate, will stimulate protein kinase A. And as a kinase, protein kinase A will phosphorylate proteins. So one of the proteins that is phosphorylated is the vesicle that contains aquaporin. So this is the aquaporin to water channel. So once this vesicle is phosphorylated by pKa, the vesicle integrates into the apical membrane or the cell membrane. So remember that a vesicle has the same structure as the plasma membrane. And so once it fuses with the plasma membrane, aquaporin 2 is integrated and will then be available. So the action of aquaporin 2 would be to serve as channels or passageways of water. So through aquaporin 2, water will be reabsorbed into the cell. Once it has reabsorbed water, it will then reform the water channel containing vesicle and will be led into degradation. So the phosphorylated proteins will prevent the endocytosis of the apical membrane with aquaporin. So what does that mean? The action of AVP, vasopressin, leads to prevention of the involution of these aquaporin 2, increasing their levels in the cell membrane. So once we block this receptor, the downstream effects will also be inhibited. Vasopressin will not integrate aquaporin with the cell membrane, preventing water reabsorption. At the same time, it will facilitate the removal of aquaporin 2 water channels in the apical membrane, preventing long-term water reabsorption. Okay, so a while ago, I introduced you into the concept of decompensated heart failure. So in patients who are decompensated, their symptoms are very severe. And so a way to help these patients would be to promote their heart um, to facilitate the contraction of their hearts so that their cardiac outputs increase and their symptoms resolve. So here um, we have agents that act on the beta adrenergic receptor. So agonists, once they act on the receptor, will help the heart contract and help resolve symptoms. But that is a short and temporizing measure. Remember that in the pathophysiology of heart failure, one key concept is the activation of the sympathetic nervous system. And by activation of the sympathetic nervous system, the heart remodels and the body reabsorbs water. And so that is central in perpetuating the vicious cycle. So here we have a dilemma. Patients with heart failure have cardiac output that is low. And so if we give them beta blockers, are we mechanistically preventing their heart from functioning? Remember that the beta receptor is important for inotropy, strength of contraction, and chronotropy, the rate of contraction. So if we give them beta blockers, are we um, causing them to experience more severe heart failure? So here is the answer. Patients with mild to moderate chronic congestive heart failure demonstrate improvements in symptoms, hospitalizations, and mortality when taking beta blockers. So this is a paradoxical finding. At initiation of beta blocker therapy, we see that there is an acute decrease in systolic function. But, so this is the important caveat, this recovers and improves beyond baseline at 2 to 4 months of therapy. So at baseline, they have low cardiac function. Once you give them beta blockers, this goes down, but quickly after 2 months of therapy, this goes up again and even improves, increasing more than the baseline heart function. So that is what we are after for. Beta blockers improve survival. So this is how it works. By preventing myocardial ischemia without affecting serum electrolytes. And thus, it decreases the occurrence of abnormal heart rhythms that are common in congestive heart failure patients. So, by giving beta blockers, the patient's heart receives more oxygen, and thereby it counteracts one of the most common etiologies for heart failure, which is coronary artery syndrome, preventing damage to the heart, thereby slowing the progression of heart failure. So, the two most common beta blockers that we use are, for heart failure, metoprolol and carvedilol, which are cardioselective beta blockers. Cardiac glycosides. Cardiac glycosides have three major effects in heart failure. Number one is positive inotropy. Second is effects on electrophysiology, or the conduction system of the heart. And third is inhibition of the sympathetic tone. Its increase of cardiac contractility and strength is due to its inhibition of sarcolemmal sodium-potassium ATPase, and this leads to an increase in the releasable calcium from the sarcoplasmic reticulum. Once there is increase in calcium, then the ability of the heart to contract due to the presence of calcium increases. Its electrophysiologic action involves a decrease in automaticity. So this means that the baseline rate of firing of action potentials in the heart decreases. This leads to an increase in maximal diastolic resting membrane potential in atrial and atrioventricular nodal tissues. So what does this mean? When the resting membrane potential of the atrium and the cardiac conduction system, the atrioventricular nodal tissues, becomes more negative at diastole, that means that it will have a harder time becoming more positive and a harder time reaching that threshold for an action potential generation. And therefore, diastole, or the resting of the heart, the time by which it is filled, is prolonged. And therefore, this helps especially in heart failure with preserved ejection fraction. Next, it inhibits sympathetic tone. It favorably influences the carotid baroreflex responsiveness to changes in carotid sinus pressures. Remember that in heart failure, the cardiac output decreases so that there is less stimulation of the baroreflex circuit in the carotid bodies and the aortic arch. So this decrease in the stimulation of the baroreceptors leads to a firing of the sympathetic nervous system. So what cardiac glycosides do is that they help the baroreceptors become more sensitive so that even with decreased cardiac output, they are already stimulated, and therefore that leads to an inhibition of the sympathetic nervous system tone. Cardiac glycosides also decrease the activity of the sympathetic nervous system at the level of the hypothalamus. So this image is a depiction of intracellular calcium regulation in muscle cells. And remember that the heart muscle is not exempted from this rule. So here highlighted is one cell, and a special organelle within this cell is the sarcoplasmic reticulum. The sarcoplasmic reticulum SR is a specialized form of endoplasmic reticulum that holds calcium. So its primary function is to be a reservoir of calcium. First, let us understand that the exterior of the cell has high sodium and low potassium, and the interior has low sodium and high potassium. Let's then focus our attention on the regulators of ions inside the cell. So these are ion transporters. First is the sodium-potassium ATPase pump that, by cleavage of adenosine triphosphate, releases energy so that 3 ions of sodium leave the cell. At the same time, 2 ions of potassium enter the cell. So the effect of this enzyme is to continuously decrease the levels of sodium inside the cell. Okay. By decreasing the levels of sodium inside the cell, this pump creates a gradient so that there is high sodium outside and low sodium inside. Therefore, when the sodium channels open, the sodium would just have to go along its concentration gradient and enter the cell. At the same time, this pump, by decreasing the levels of sodium inside the cell, also power the sodium-calcium exchanger. Okay? The sodium-calcium exchanger utilizes the concentration gradient of sodium so that as sodium moves from its high concentration outside into its low concentration inside, it concurrently extrudes calcium. So as sodium enters, calcium leaves the cell. Okay, so this exchanger right here decreases the levels of calcium inside the cell. Okay, there are two forms of the sodium-calcium exchanger: a polarized one, which decreases calcium inside the cell, and a depolarized one. Whenever the cell becomes activated by an action potential, it reverses its activity so that when the cell is depolarized, more positive, due to an action potential, calcium enters and sodium leaves the cell. So again, the sodium-calcium exchanger has two forms or two states. In its normal resting state, it causes sodium to enter the cell, and this entrance is due to low sodium inside due to the sodium-potassium ATPase. At the same time, it causes calcium to leave the cell. But when the heart muscle cell is depolarized, acted upon by an action potential, especially during a contraction, it causes the sodium-calcium exchanger to reverse its polarity. So calcium at this phase then enters the cell and sodium leaves the cell. Okay, so we also have this calcium pump or ATPase, which cleaves adenosine triphosphate to pump out calcium into the outside of the cell. So the next ion transporter is the L-type calcium channel, which is inhibited by diltiazem and verapamil. Okay, so as you will observe, the sodium-calcium exchanger creates low levels of calcium inside the cell, and the calcium pump also creates low levels of calcium inside the cell. So that inside the cell, in a polarized state, more negative than usual, the opening of the L-type calcium channel causes the calcium to move from high concentration outside to low concentration inside. So it is a movement along the concentration gradient, and therefore this is a facilitated diffusion. Let's now take a quick look into the sarcoplasmic reticulum. The sarcoplasmic reticulum has a calcium channel, which is the ryanodine receptor. Okay, ryanodine receptor. So this calcium channel, once it is open, causes the stored calcium inside the sarcoplasmic reticulum to leave, and therefore it increases intracellular calcium because it has exited the organelle and entered the cytoplasm. The last type of channel in the sarcoplasmic reticulum is SERCA, which is the smooth endoplasmic reticulum calcium transporter, which will cause calcium to enter and be sequestrated in the sarcoplasmic reticulum. So it causes calcium in the cytoplasm to be stored in the sarcoplasmic reticulum. So knowing these ion exchangers and transporters, let's now insert the mechanism of digoxin. So digoxin will inhibit the sodium-potassium ATPase. Once this is inhibited, the levels of sodium inside the cell will increase. So this increase in intracellular sodium causes the cell to become depolarized because there are more cations inside the cell. So its overall charge will become more positive since sodium is a cation. So once the cell is depolarized, the sodium-calcium exchanger is forced to um, be in this depolarized state. And at the depolarized state, the sodium-calcium exchanger causes influx of calcium. So by inhibiting the sodium-potassium ATPase, digoxin through the sodium-calcium exchanger causes an increase in intracellular calcium. Okay? So at the same time, because the inhibition of sodium-potassium ATPase by digoxin is a chronic matter, so it is prolonged, the high levels of calcium inside the cell will force the SERCA to sequestrate this calcium in the sarcoplasmic reticulum. And therefore, intracellularly, in the cytoplasm, there is high calcium, but more importantly, it increases the concentration of calcium in the sarcoplasmic reticulum, and therefore helps the cell, the cardiomyocyte, to be more efficient in contraction because it has stored a lot of calcium. Lastly, let's go into inotropes in the form of beta, adrenergic, and dopaminergic agonists. In decompensated congestive heart failure from reduced cardiac output, the principal focus of initial therapy is to increase contractility, as I discussed a while ago. To do this, we utilize agonists that are uh, of the catecholamine family. So you have dopamine, which acts on the dopamine receptor, and dobutamine, which acts on the beta 1 receptor. Okay? So these two agents will stimulate the GS adenylyl cyclase, cyclic AMP, PKA pathway, much like other catecholamines. So the increase in CAMP activates protein kinase A, and the catalytic subunit of protein kinase A phosphorylates a number of substrates that will enhance calcium-dependent myocardial contraction. So that will increase inotropy, and it also accelerates relaxation. So when the relaxation period is shortened, then that means that for a period of time, let's say 1 minute, the heart will be um, in decreased time of relaxation and increased time of contraction. So that means that the heart rate increases. So this is the mechanism of positive chronotropy. Adjuncts to dopamine and dobutamine are phosphodiesterase 3 inhibitors, examples of which are milrinone and inamrinone. Milrinone and inamrinone prevent the degradation of CAMP and thus increase its steady state levels and therefore increase the activity of protein kinase A. However, we should remember that these agents should not be used chronically. We only use them when the patient is in a decompensated state to help the heart pump faster and stronger to move that fluid that is retained. Okay, after that, when the patient leaves the decompensated state, we continue the patient on the agents that we have discussed a while ago, which provide survival benefit. Why should we not use these agents chronically? Because CAMP stimulates heart muscle cell death, okay, apoptosis. And at the bigger scheme of things, it increases the risk of hospitalization and death. So this image shows us the cardiac excitation, contraction, coupling, and its regulation by inotropic drugs. So the final common pathway is an increase in calcium. We have already discussed how cardiac glycosides work. Now let's focus our attention into how the inotropes, which are dopamine and beta 1 receptor agonists, work. So the catecholamines will bind to the beta receptor, which will stimulate GS. So this is a G protein coupled receptor, which then will activate adenylyl cyclase, which converts ATP into CAMP. CAMP activates protein kinase A, which will open the L-type calcium channel so that calcium enters the cell. The protein kinase A will also activate the ryanodine receptor so that calcium from inside the sarcoplasmic reticulum leaves the sarcoplasmic reticulum and increases the concentration of calcium in the cytoplasm. Calcium, once high in levels in the cytoplasm, will then be able to interact with the myofilaments of the heart muscle cell through troponin C and facilitate contraction. Okay, so CAMP then is degraded via phosphodiesterase 3 into 5' AMP. And this degradation of CAMP will then stop the release of calcium through this pathway. And so, by inhibiting phosphodiesterase 3, we increase the levels of CAMP and increase the bioavailable calcium inside the cell, and facilitate heart muscle contraction. Okay, so um, in summary, here in this pathway, we see how catecholamines help the muscle cell to contract, how phosphodiesterase inhibitors help the muscle cell to contract, and how cardiac glycosides, by increasing calcium inside the cell and inside the sarcoplasmic reticulum, help the muscle to contract. So, we have discussed a lot of agents. Let's take a look at how we utilize these agents in a stepwise manner for the treatment of heart failure. So this is the treatment guideline for heart failure, but this is not um, your competency as students. Okay, so stage A, the patient is at high risk for heart failure, but without structural heart disease or symptoms of heart failure. These are usually patients with hypertension, atherosclerotic disease, obesity, diabetes mellitus, metabolic syndrome, or patients using cardiotoxic drugs such as drugs used for cancer therapy, or with family history of cardiomyopathy. The goal of therapy is to have a heart-healthy lifestyle, prevent vascular disease, and prevent left ventricle remodeling. So drugs that we can use are ACE inhibitors or ARBs and statins. At the higher stage, stage B, structural heart disease is seen, but the patient does not exhibit symptoms of heart failure. So these are usually patients with previous myocardial infarction, left ventricular remodeling, including left ventricle hypertrophy with low ejection fraction, or patients with valve disease. So the therapy is to prevent the occurrence of symptoms and prevent further remodeling. Drugs that we can use are ACE inhibitors or ARBs, beta blockers in appropriate patients. In selected patients, we can implant a device that will help with arrhythmias, or we can revascularize. In stage C, these are patients with structural heart disease with prior or current symptoms of heart failure. So these patients are usually patients with known structural heart disease and with signs and symptoms. The goal of therapy here would be to control the symptoms, prevent hospitalization, and prevent mortality. And drugs that we can use for these patients are diuretics. As we have discussed a while ago, diuretics are symptomatic treatment. Drugs that can treat comorbidities of hypertension, atrial fibrillation, a form of arrhythmia, coronary artery disease, or diabetes mellitus. Drugs for routine use in patients with reduced ejection fraction. So here, this is systolic dysfunction. We can use diuretics, ACE inhibitors or ARBs, aldosterone receptor blockers, beta blockers, aldosterone antagonists, and ivabradine, which is a sensitizer for calcium. Drugs for use in selected patients with reduced ejection fraction are the combination hydralazine, isosorbide dinitrate, ACE inhibitors, and ARBs, and cardiac glycosides. So here you see the symptomatic use of cardiac glycosides. Okay, in stage D, which is refractory heart failure, which means that heart failure does not stop from worsening or is resistant to treatment. So these are patients with marked heart failure symptoms at rest. So remember that our definition of heart failure a while ago is symptoms at exertion. But if you already have refractory heart failure, you see the symptoms at rest. Um, these are patients with recurrent hospitalizations despite medical therapy. So here, at this stage, patients are usually treated palliatively. Okay, so we already know that this patient is bound for death, and so we help the patient with his or her symptoms to improve the quality of life. So the goals are to control the symptoms, improve the quality of life, reduce readmissions, which are associated with medical bankruptcy, and establish end-of-life goals. Options: advanced care measures, heart transplant, chronic inotropes, temporary or permanent mechanical support via a left ventricular assist device, experimental surgery or drugs, palliative care, and um, implantable cardioverter defibrillator deactivation. So we stop the aid for arrhythmia.